So in my role as the lead for the Directors of Medical Education here in the East of England, I was invited by the leads within the quality team here within HEE to come and give some advice and some thoughts about how we could really make this process work effectively, how we could make it work well for Directors of Medical Education, for medical education managers, and the individuals within trusts who are going to actually have to complete and work with the quality framework. And so I was really thrilled to be invited so that we could actually have some influence in the process, some influence in how the ideas were developed about what we'd be actually doing on the ground to implement the new quality framework. Interestingly, here in the East of England, I think that we were very much at the forefront of already assessing quality of medical education and the wider multi-professional education more than other regions. And that's because we'd always had a multi-professional approach to assessing the environment and the quality within trusts. But that system wasn't widespread across the whole of the UK, and particularly within England. And so I can see from an HEE perspective why one would want to have a new system, and a system that was dedicated to being multi-professional, and a system that was designed to start to be able to compare all areas of the country in a very consistent way, underpinned by standards. And we'd never had that system before, not only to have standards for assessment, but to really do it in the environment of improvement. Through my involvement, I became really very keen to ensure that this would become the new way forward, that we'd be doing this within the East of England. And it replaced the old visiting system, which was resource heavy. It was resource heavy both in terms of preparation for it, for the number of people involved in a multi-professional visit, both from the trust perspective and the provider perspective, but also from that within HEE and arranging visits. As a Director of Medical Education, then I contribute to forming the report. Royal Papworth, we tend to be quite a multi-professional education department anyway. Other trusts are not so similar and have actually quite divided ways of delivering education. So I contributed very broadly to completing the actual self-assessment forms, and then being able to create the action plans that result from those, to be able to contribute to the regular reassessment and hopefully improving the delivery, the quality and the governance underpinning education as a result of those. I think there are some very clear examples in my area and within medical education where I can see that very simple things have made a dramatic improvement on trainees' ability to receive good quality medical education. It may be something very simple, holding a bleep, reorganising the timing of training, avoiding certain times of the day when they're busy on the ward and need to be made available to be able to actually attend educational events. And so very simple changes can be very effective in making sure that trainees have improved learning environments and improved quality of direct education. Sometimes we've identified that there have been very high risks identified with the RAG system. And when we've seen those, sometimes we've recognised that really very large-scale changes are needed to be made. And certain departments may be highlighted through triangulation of information from GMC surveys, from the new HEE national survey, that show us that you need to really make significant changes. And through high RAG rating, it can highlight that it's really important to make big changes and as soon as possible. So it's very clear in successful organisations that great leadership creates successful organisations. But I think with that, there are three pillars that are so important. It's the research, the innovation, the development of organisations, and research of clinical areas, clinical excellence and delivery of care, but underpinned by effective medical education. And without effective medical education, we don't have the workforce for now, we can't deliver the workforce for the future, and both of those are absolutely intrinsically required to deliver excellence and quality in patient care. And so what we're striving to do here is to ensure key elements of quality in medical and multi-professional education to drive the workforce for the future. Without that, we can't deliver the quality in patient care. It's so important that we recognise, as we do for quality of patient care, that education in principle requires the right education environment. It requires our learners to be able to thrive so that we create the successful workforce of the future. And without the framework, I think we were really a little lost. This provides a framework, standards against which to assess, a governance framework to troubleshoot areas of concern. And I think we should embrace that to show that we can drive improvements in education through recognising areas for improvement, but celebrating and sharing areas of success too.